All right, are we ready to go? Set, we're right at 12:30. Can everybody? Okay, great. So yes, thank you, Vicki. I am Hannah Smith, nurse practitioner in general pediatrics, and Katie Shelor is one of our nurse practitioners in pediatric neurology. So she's going to address specifically melatonin and pediatric headache, but I'll go over just some general information on melatonin related to sleep in the pediatric population. All right, so learning objectives for today are to review the physiology of endogenous melatonin production, as well as its function throughout the lifespan, describe current evidence and available guidelines, of which there are a few, but I've got a little bit to show you, that review the indication for use, efficacy, and safety of melatonin in the pediatric population. And then Ms. Shelor will identify the role of melatonin in pediatric headache disorders and its possible use as a treatment modality. Yeah. All right. I like to set things in a historical context. The first time you see melatonin mentioned in the in literature is around 1917, although at the time we didn't know what we were looking at. Someone noticed that if they injected an acetone extract of bovine pineal glands into tadpoles, they would be much lighter in color than their cohorts. So the follow-up for that in the 1950s, Dr. Aaron Lerner, who was a dermatologist, isolated an indole hormone from the bovine pineal gland and recognized that it caused hypopigmentation in frogs. So you can see one of the frogs he submerged in a melatonin solution on the right there as compared to prior to being submerged. So it was first investigated as a possible treatment for disorders of pigmentation, such as vitiligo. That was not successful, but as they were investigating that possible use, people noticed that it caused some sleepiness and mediated sleep onset, and that is how we have arrived at its current use today. Quick review of the chemistry, which you will probably forget. Melatonin is a monoamine neurotransmitter. It's a member of the indolamine subgroup. So this subgroup includes histamine and serotonin as well. The other subgroup of the monoamine neurotransmitters would be the catecholamines, such as dopamine, epinephrine, and norepinephrine. Chemical precursors to melatonin include tryptophan and serotonin. It is synthesized and secreted from the pineal gland. You also see production in the retina and gastrointestinal tract in humans. Only the pineal gland and retinal secretions follow circadian rhythms in a diurnal pattern that we'll talk about in a minute, though. So this is the diurnal pattern of melatonin secretion in humans. Plasma and saliva levels are both elevated throughout the night. Hopefully you can see my cursor right here around like 7 or 8 p.m. on this graph. You see that endogenous melatonin levels begin to rise. This is typically about 2 hours before sleep onset in normal humans. It's termed the dim light melatonin onset, and it's used as a marker of circadian rhythm, which will become relevant when we talk about timing of administration for exogenous melatonin a little bit later in the talk. Secretion is regulated by the suprachiasmatic nucleus in the hypothalamus, or the so-called biologic clock, and its secretion is enhanced by darkness but inhibited by retinal perception of light, and that's whether it's natural light or artificial. I did find it interesting there is a seasonal variation to melatonin secretion, since dark periods are longer in the winter months, so it explains why I'm always so much more tired during that part of the year. Hopefully that's why. Melatonin secretion throughout the lifespan. So quite low to undetectable in newborns, but then peaks quickly, and the highest levels are found throughout childhood. There is a precipitous decline in melatonin secretion beginning at puberty, and then it continues to decline throughout the rest of the lifespan. In neonates, again, quite low levels. You begin to be able to measure melatonin around 9 weeks postnatal. And then at that point, the secretion doesn't follow any particular pattern related to circadian rhythm, as that is still developing in the neonate. But it begins to consolidate into more of the diurnal pattern around 3 to 4 months of age. Pretty interesting. Melatonin secretion in human breast milk does follow the same circadian rhythm that you see in the mom's serum and saliva levels. So melatonin in breast milk will begin to rise around 8 p.m., tends to peak at 3 a.m., and then by morning and throughout the day will be almost undetectable. the breast milk levels are about 35% of maternal serum levels at any given time. And then you've got several articles listed here, pretty consistent findings across all of these articles as far as the pattern and levels of melatonin detected in maternal milk. And some of the recommendations in some of these articles talked about being sure that moms are feeding in dim light throughout the night, because if they're inhibiting their own melatonin secretion because of light perception, theoretically that could also inhibit the levels in breast milk. And it is thought that the melatonin in breast milk helps with the entrainment of the infant's circadian rhythm as they're developing that over the first few months of life. Melatonin at puberty. So as I mentioned, it does decline pretty quickly around puberty. There's been some discussion in the past about whether or not this is simply correlative or causative, and there was concern because of some of the effects of melatonin in animal models that its exogenous administration in children would affect pubertal development. That doesn't seem to be the case, but this was a great study looking at serum or salivary melatonin levels in children, and relating it both to Tanner staging, age, BMI, and sex. So these kids were given melatonin, their melatonin levels were measured for after 10 days of consistent sleep, wake, and light, dark environment. And they measured area under the curve and max concentration of melatonin in saliva. They used linear regression analysis and found that there was a very close association, a negative association between Tanner stages and salivary melatonin levels. So as Tanner stages progressed, melatonin levels dropped, and girls overall secreted more melatonin than boys. However, age and body mass didn't have a significant association with salivary melatonin levels. So there are some articles I read working on this that suggested the decrease was related to increasing body mass size with a fixed pineal gland size. But this and a few other studies like it seem to suggest it really does have more to do with pubertal development than actual BMI. Again, it's all correlative data as opposed to causative. And then this is one of my favorite pictures from the whole talk. This is looking at the effect of retinal light perception on endogenous melatonin secretion. So it was a cohort of both adult and children, or child participants. We had 42 participants altogether. The kids in this study were aged 7 to 11 years. We're going to talk in a minute about the physiology, but the important thing looking at this slide to know is that retinal light perception inhibits pineal secretion of melatonin, and the rod photoreceptors where melatonin receptors are found in the retina, those photoreceptors are tuned to the blue-green light spectrum. So this is why we're concerned about blue light, and one of the reasons we would be concerned about blue light in children, because that tends to have a more significant effect on endogenous melatonin secretion. So if you look over on the left, you've got adults, baseline light exposure, and then they were exposed to either warm light or blue light in the evenings, and it compares their endogenous melatonin secretion on the left to after light exposure on the right. Certainly had an effect on adults, but not nearly as significant as what you see in children on the right. So on the right, we've got children. The upper one is exposure to a warm light spectrum in the evenings. Did reduce melatonin secretion, but not quite to the same degree as the blue light. So if you look there, I mean, this blue light exposure, it almost obliterated endogenous melatonin secretion. You've got all of this beautiful secretion on the left and then almost nothing. So I think a great picture of why it is we want our kids turning screens off in the evenings, especially blue light, but any light's gonna have an effect. Okay, so moving into pharmacokinetics. This is one of the curious things about melatonin is the way exogenous administration affects the body. So the phase response curve for melatonin is going to be really important to understand in order to know how and when to give melatonin to kids when it's needed. There are two therapeutic effects of exogenous melatonin. It has a hypnotic effect. This is the one for which it is probably most well known. And then it also has a chronotropic effect. The hypnotic effect is the one that we typically use it for. It's not a universal effect. does seem to happen in at least 80% of children, but there are some people that just don't respond, at least when it's given at the time of bedtime. The chronotropic effect, however, is universal. It will have this effect in every person that takes it. The chronotropic effect is melatonin's ability to shift circadian rhythms in relation to the 24-hour clock and essentially move the time when the pineal gland secretes melatonin endogenously from prior to exogenous administration. And this is the timing of melatonin administration to get these effects is relevant to the individual circadian rhythm, not the 24-hour clock, which again, we're going to get into a little bit more later. So this graph is demonstrating the two possible chronotropic effects that exogenous melatonin will have. It will be either a phase advancement or a phase delay. You see the purple line in this graph is representing the firing rate of the suprachiasmatic nuclei or circadian pacemaker, but think of it in this case as wakefulness. And so you see high during the day, drops during the night, ideally, and then high again during the day. It is inversely related to endogenous melatonin levels. Depending on the time of administration of exogenous melatonin, melatonin will either produce a phase advancement where endogenous secretion is moved earlier in relation to the 24-hour clock, or a phase delay in which endogenous melatonin secretion is shifted later in relation to the 24-hour clock. So that green line would result in an earlier sleep onset. A phase advancement is earlier sleep, and a phase delay is later sleep onset, which I can't imagine why we would ever want in a child. All right. And so this graph is going to show you a little bit about what kind of chronotropic effect you will have depending on when you dose your exogenous melatonin. This is taken from a study by Burgess et al. Conducted in 2010. It's one of the principal studies demonstrating the phase response curve for melatonin. It is an adult study, but similar effects are observed in children, and this is the one that had the best visuals really to discuss. So in this particular study, participants were maintained in a lab setting with fixed light dark cycles, and then measurements of their saliva melatonin levels were collected to determine when their dim light melatonin onset was, so that they could then compare the results after giving either melatonin or a placebo. The solid line is 0.5 milligram dosing, and the dashed line is 3 milligram dosing. The y-axis over here on the left is showing phase shift in hours, with 0 being the baseline dim light melatonin onset. So that would be about 2 hours before when they were falling asleep is this 0 line going down the middle. Above, the phase advancements are earlier sleep onset, and below 0, the delays are later on sleep onset. The x-axis, typically when you read about melatonin, it's going to talk about dosing in relation to the dim light melatonin onset. That's not a thing that we can easily determine in general practice. So this graph is relating it to sleep midpoint, which is considered to be an acceptable substitute, since you can actually calculate that in an office visit, as opposed to the dim light melatonin onset. So basically what I want you to see here is that there is a particular window in which when you administer melatonin to a child, you will actually get earlier sleep onset. That goes from about 13 hours prior to sleep midpoint to 6 hours prior to sleep midpoint. As you get into the middle hours of the night, closer to that sleep midpoint or in the morning, if you're giving melatonin then, it's going to produce a phase delay or a later shift in the endogenous circadian secretion of melatonin. So moms that are having kids wake up at 3 a.m., giving them melatonin to get them back to sleep, I've certainly been that mom in the past. They're still going to get the hypnotic effects because that's irrelevant in relation to circadian rhythm. But in the long run, if that's a repeated thing, it will eventually shift endogenous melatonin later and cause long-term sleep problems. I did forget to mention, so if you notice too, the dose doesn't matter. Whether it was a 0.5 milligram dose or a 3 milligram dose, you got the same magnitude of shift. It does seem to be better to give higher doses earlier in the evening to avoid some of that delay, but the magnitude is irrelevant to dosing. I've got 2 studies here that show just that, that it is certainly more relevant when you give your melatonin than how much you give. So this was a randomized controlled trial of 13 kids with delayed sleep phase disorder. They compared a 0.3 milligram dose with a 3 milligram dose, and they compared timing at 1.5 hours versus 6 hours prior to dim light melatonin onset. Both doses produced phase advancement, so earlier sleep onset, after 4 weeks of use. The magnitude of that advancement was more strongly correlated to the timing of administration, with earlier administration being more effective. And then the dosing didn't actually affect the magnitude. You got the same response. It just mattered when you gave it. Another study, again, similar results. These were mg per kg dosing, so it was either a 0.5 milligram, 0.05 milligrams, 0.1 milligrams, or 0.15 milligrams per kilogram given to children aged 6 to 12 years for a week. Did have a placebo and a treatment arm, and was a blinded study. Again, the effect size was not different for any of the 3 dosing arms, and all of them were effective in shifting sleep onset earlier. The earlier the administration, the higher magnitude of the phase advancement. The hypnotic effects were observed regardless of when it was administered. And so, yeah, again, dosing not as important as timing. Indications for use of melatonin, and there's plenty of evidence on efficacy, and you'll see there's less on safety. So I'm going to quickly just differentiate a little bit for you without going into diagnostic criteria, a delayed sleep phase disorder versus psychophysiologic insomnia. What most parents, I feel, are using melatonin for is the psychophysiologic insomnia. So this is the poor sleep hygiene on their phones late at night to calm down, quote unquote, TVs in the bedroom, etc. This is trouble falling asleep, and that's where that hypnotic or soporific effect of melatonin is typically used, just to get them to fall asleep. The more accurate, I suppose, use for melatonin might be this delayed sleep phase disorder, where you have an actual difference in the circadian rhythm and endogenous melatonin secretion in comparison to the 24-hour clock. So prevalence for this is about 7 to 16% in adolescents and young adults, but the pattern begins developing in earlier adolescence. Sleep, and these are kids that are having trouble falling asleep. So they're falling asleep 3 to 6 hours later than conventional bedtimes. They do have normal sleep quality and duration once they fall asleep, but the times are delayed. And it's thought to be related to an extended intrinsic circadian cycle of at least 24.75 hours, if not longer. These kids are not waking up well for school. They're permanently feeling jet lagged. And this is one of the areas that most of the research looks at, is how to use melatonin to help shift these kids back to a more conventional circadian rhythm. Typically, you would treat that with both melatonin and bright light therapy, which we wouldn't be doing in most of the settings here at Carilion Children's, but interesting to know about. And again, as we talked about a moment ago, lower doses are just as effective to get that chronotropic effect on kids as the higher doses. It matters more when you give it. The goal of treatment in these kids would be a phase advancement for endogenous melatonin secretion. And it requires dosing of melatonin several hours prior to the individual's dim light melatonin onset, which you can approximate by calculating sleep midpoint. And we'll get into that timing in more detail later on. Higher doses are needed to get the hypnotic effects if you're using it just for the psychophysiologic insomnia, more in the 3 to 10 milligram range. But sometimes you'll run into some tachyphylaxis using these doses, or sleep maintenance insomnia, because melatonin will help them fall asleep but not stay asleep. And in fact, if it's too high of a dose that's taking longer to be metabolized, you can end up having it in the system in those wee hours of the morning, where you're now potentially risking a sleep delay or phase delay in endogenous melatonin secretion. Do you have to combine it with behavioral changes? You can't just give them melatonin and expect it to fix everything. I'm going to go through some of these studies a little bit quicker to make sure Katie has time to present on headaches. This one is a review of 19 randomized controlled trials looking at efficacy for melatonin. Across the board, it did improve sleep latency, so time from lights out to sleep onset, and sleep duration. Did not improve the number of times a child woke per night, and had some variable effects on function and behavior. This is the immediate release melatonin as opposed to delayed release, which there are some formulations for. these are two subsequent studies on the same cohort. The original was a randomized controlled trial looking at daily melatonin dosed at 3 milligrams or 6 milligrams depending on body weight. This was used for sleep onset rather than circadian rhythm shifts. Definitely was effective, ameliorated sleep onset problems in 87% of children. About 9% discontinued because they didn't need it anymore, and about 18% experienced adverse effects, most common being headaches, hyperactivity, dizziness, and abdominal pain. The follow-up was a 3.7-year questionnaire follow-up on the same cohort or a subset of them, and similar results. Had dizziness, bedwetting, sleep maintenance, insomnia, and headache as the most common side effects, but only 3% of participants discontinued because of those side effects. What's important to know is this was only parent report. So there was no kind of laboratory evaluation of endocrine function. There was no Tanner staging. And so it's 3.7 years of daily use, but it was really just looking at reported adverse events as opposed to any effects on development in children. And this is the other quote unquote long-term safety study available. It was only 52 weeks. It was funded by a pharmaceutical company who was manufacturing the prolonged release melatonin that was studied. Didn't have significant side effects or adverse events noticed. It was mostly fatigue and mood swings, and found melatonin to be effective, but limited by funding and duration of the study. One of the few guidelines available on melatonin use in children. It's from the American Academy of Neurology. It's specifically for children with autism. A summary of their recommendations are to start with behavioral modifications, only add melatonin if that was ineffective, and review with families that there really isn't long-term data on safety in pediatric use, even though it appears to be safe at this time. All right, so one thing to know about the over-the-counter melatonin. This is a dietary supplement. It's not regulated by the FDA. And so there are some concerns about accuracy of labeling. This one study, Erland and Saxena from 2017, it was conducted in Canada, but it found melatonin content ranged from 83% less to 478% more than what was labeled on the bottle. And even within lots of the same company's product, you could have variance as much as 465%. So you really don't know what kind of dose you're getting if you buy it over the counter. So for that reason, it's recommended that you use pharmaceutical grade if you're going to use it in children, just so you know what you're actually dosing them with. Some of them had serotonin in the over-the-counter formulations as well. The European Pediatric Neurology Society does have a clinical practice guideline as well. It recommends considering melatonin for children with sleep onset insomnia or difficulty waking at conventional times. That second sign will get more at the kids that might have a sleep phase delay disorder. Typically not effective for sleep maintenance, which I think we've mentioned a little bit before. It's really more helpful for sleep onset or shifting that circadian secretion, endogenous secretion. They note that they think it's probably safe after 6 months, but that was sort of extrapolated from some neonatal studies on using melatonin for neuroprotective effects. There's no established safe minimum age for melatonin, although it is used in infants at times. If you're using it for the chronotropic effect, aim for 3 to 4 hours before actual sleep onset. If you're using it for the hypnotic, give it about 30 minutes before bedtime. Again, for the chronotropic effect, you're going to start with the lowest possible dose, even as low as a 0.5 milligram, and increase weekly by intervals of a 0.5 milligram to a max of either 3 or 5, depending on body weight, over the course of several weeks. Especially for the chronotropic effect, they recommended using it for at least a month to ensure that you actually achieve a phase advancement in endogenous secretion. That wouldn't necessarily be needed for the hypnotic, but if you're trying to make a phase shift, you're going to need at least a month's treatment. And then if you're using it for sleep onset only, then you're going to go in the 1 to 3 milligram range, about 30 minutes before bedtime. So there is actually a sample dosing schedule in here for a child, for instance, falling asleep at 2 a.m. and we're waking at 11 a.m. If you were to calculate that, sleep midpoint would be 6:30 in the morning. Chronotropic effects, you want to dose 10 hours prior to sleep midpoint. So in this case, that would be at 8:30 p.m. So you're going to start at 8:30 with that 0.5 milligram or 1 milligram. I think in this recommendation, they didn't have access to a 0.5 milligram dose. Start at 8:30, use a 0.5 milligram for 4 to 5 nights, move it back to 8 p.m., continue for 4 to 5 nights, and continue eking that administration back 30 minutes every week until you get the kid to a more conventional schedule. And then once on the correct schedule, you can continue to maintain them at a 0.5 milligram to 1 milligram about 2 hours before sleep onset. All right, I'm going to pass it over to Katie to finish out and discuss headaches for a few more minutes.
So I just want to talk a little bit about the physiology of headaches. So we know that there's cortical spreading depression that kind of triggers these trigeminal afferents, and then these inflammatory sort of changes begin. There's some sort of neurogenic kind of inflammation, and this is what kind of prolongs and intensifies migraines. And then there is a loose theory saying that, hey, maybe there are these oxidative stressors or free radicals that may have some loose correlation to migraine. So these are important because melatonin, the mechanism, so there are studies saying that, hey, there are some anti-inflammatory sort of properties of melatonin. So, right, we've got all this inflammation in the brain during a migraine, tension headache, or other types of headaches. So hopefully that is helping with that part of it. And then melatonin also has some effects of how these nerve endings are so excitable. So melatonin can kind of calm that down. And also melatonin has some free radical sort of scavenging properties, so hopefully it's taking care of those free radicals. There are many studies that show people with neurological disorders have lower levels of melatonin overall, so anything like Parkinson's, but I'm primarily looking at headaches, so headaches is definitely on that list. Okay, so this is just a little bit like a theory of how kind of some of these things work. So melatonin is used as kind of a neuroregulator. So melatonin inhibits something called orexin. So sometimes if orexin is kind of just left to go and melatonin is not there to check it or inhibit it, we can kind of get this orexinogenic dysfunction. And so that leads to serotonin release, and then we get a serotonergic effect. And then when that serotonin is released, then we have activation of the nerve endings of the vessels in the meninges. And then there's also some speculation that this causes abnormal cerebral vessel dilation, which is not necessarily a cause of these headaches, but can definitely make these worse and prolong these. So these meninges will release pro-inflammatory peptides, which cause headaches. So sleep or lack of melatonin may be a trigger for headaches, sleeping too little or too much, or being on an odd sleep schedule. So having an odd circadian rhythm can definitely increase the amount of headaches that you're having. Circadian rhythm dysfunction is widely accepted as possible cause of cluster headaches. And then migraine sufferers complain more about insomnia or kind of sleep initiation. And sleep is important because cortical activity slows during sleep function, and it functions to kind of clear the brain of the waste and that sort of thing. And maybe this is the reason that sleep aborts headaches. You've got kind of that increase in melatonin, and then you're kind of decreasing that orexin effect. Okay. And then, so I'm just kind of playing off of what Hannah's already said. So we can use this for headaches. So this endogenous melatonin, I normally recommend to my patients that we turn off screens about 1 to 2 hours before bedtime, practice good sleep hygiene, being on a good schedule. Teenagers, that's super hard to do, especially the ones that like to stay up and game. So sometimes I say, all right, well, let's start with 15 minutes. Well, then we can go to 30 minutes and then go to an hour so they can make their own melatonin. If we do need to use melatonin, it can be used for abortive purposes or preventative purposes, more specifically for the preventative purposes. Abortively, melatonin, you can initiate sleep, and then that can decrease or stop the severity of headaches. Studies have shown that there's about 50% reduction in headaches over about 55 to 75% of participants in migraine over 3 studies, and this is pediatric population, and then 67% in tension type of headaches when using melatonin. And then you can also treat it for primary stabbing headaches and hemicrania continua because the structure is similar to indomethacin, which you would treat those with. All right. And I'm just going to go through this. So for tension headaches, they've tested it on 3 milligrams kind of across the board, 6 to 16-year-olds. And then for migraines, they did it more on weight-based, and it was 0.3 milligrams per kilogram per day, but not more than 6 milligrams. And it was a 3-month trial period. All right, and the last thing, so the pros to using melatonin for headaches, it's generally safe for short-term or long-term use in headaches. Parents typically like it because it's a conservative approach versus kind of a prescribed medication, low side effect profile. In the studies, the biggest complaint was daytime sleepiness. I think there was one participant that dropped out because of that. And then the cons are the same thing. So daytime sleepiness, some people will report nightmares, increased headaches, behavioral changes. And then there's not been any really big long-term studies on migraines, tension headaches for the pediatric population for melatonin use. So we can use it, 1 to 3 milligrams seems to be acceptable, or 0.3 milligrams per kilogram per day for tension headaches and migraines. People that are also having sleep issues, I think that's another reason to consider it. So if you have a child that has sleeping problems and they also are having headaches and migraines, this might be a good place to start, is melatonin supplementation, as long as they'll stick with it. And then obviously, if they can change their lifestyle stuff first, that would be better. And then you can also, consider it for things that are historically treated with indomethacin. All right, and I'll finish that up because I've already gone 3 minutes over.